All right, welcome everybody. If you haven't had a chance to do so, recommend and encourage folks to just respond to our poll up here. What word or two best describes your hopes for 2022? And I like the mix of personal and professional, all kind of acknowledging this impact of COVID, COVID free being the biggest, most prevalent answer here. I'm Ginny Weir. I am the CEO of the Foundation for Healthcare Quality. And on behalf of the Bree Collaborative, the Foundation, and the Washington Health Alliance, I am really grateful for everybody for joining us today and your intention to improve our healthcare ecosystem. I am joined by Nick Locke with the Foundation and Dr. Sharon Eloranta with the Washington Health Alliance. And I'm grateful for this team as we continue to tackle these big issues in healthcare and work through this pandemic. I want to start with a reflection on the CDC's definition of health equity, where every person has the opportunity to attain their full health potential, and no one is disadvantaged from achieving this potential because of social position or any other socially determined circumstances. And how can we all, within these varied systems, within our varied sectors, help our neighbors and our colleagues reach their full health potential? Just a pause for housekeeping. You are all on mute and will be throughout the day. Please write any content questions in the Q&A box that'll appear on the top of your screen, and any technical issues into the chat box. We will be monitoring both throughout the webinar. Additionally, this webinar is being recorded, and the recording will be posted on our YouTube channel, and a link to that will be sent out along with the slides after the webinar. So I'll just give one more minute to our poll everywhere over there before I stop sharing and we go into this presentation. All right. So the Foundation for Healthcare Quality has been part of our Washington state health ecosystem since the late 80s. And we've always been home to complementary improvement communities that really hope to move beyond this individually competitive system and sector kind of environment. Our vision is really that everyone in our region can live a long and healthy life. And so this mission we have is to catalyze system-wide improvement through involvement and insight from cross-organizational, cross-sector health and healthcare providers, administrators, and those with lived experience within a framework that's driven by clinical data, consensus building, feedback, and evidence-informed best practice that's really mixed with promising practice. So we house 4 care outcomes assessment programs that are oriented around measuring, benchmarking, and improving cardiac care, obstetrics, general surgery, and spine surgery, as well as our Patient Safety Coalition Smooth Transitions and the Dr. Robert Bree Collaborative. And the collaborative is a public-private, multi-stakeholder community that develops clinical guidelines through expert work groups for highly variable, inequitable, unsafe, or otherwise problematic healthcare services. We've worked in a real wide variety of topics, everything from unnecessary C-sections to integrating behavioral health screening and treatment into primary care to increasing the use of advanced care planning conversations. I also want to humbly acknowledge that we know clinical care only accounts for about 20% of our overall length and quality of life. Our social and economic factors, those places where we live, work, and play, account for a far larger portion of our length, our well-being, our quality of life. And so really the question that we're all here to ask ourselves today is, how can we utilize our existing infrastructure to better meet the needs of our community? So through the last year, our collaborative was lucky to convene a work group to develop a framework to integrate social needs into clinical care. This was financially supported by the Washington Healthcare Forum. And this part pathway starts with this organizational orientation around planning with an equity lens, and then moving into a clinical workflow that starts with identification of social need, such as housing insecurity, tracking and measurement, and follow-up. Of course, we also acknowledge the need to incent and invest in these services. And so this series on value-based care is really necessary for this model to work. Our goal is to meet the diverse needs of an individual and support individual providers and care teams with a surrounding healthcare system that's oriented around the quadruple aim of improved population health, enhanced patient experience, reduced cost of care, and improved provider satisfaction. The high number of providers who are resigning from practice, I think, is as dangerous to population health as any pandemic. And so this year, we will continue that focus on the quadruple aim, and parallel to that, continue our strategic convening with a steering committee group who will help move our framework into action for wholesale systems transformation. And we welcome you to that table as well. So today is the first of this year's value-based care change in action webinar series. 2020 saw the launch of many things, including our pandemic, and also this partnership between the Bree Collaborative at the Foundation for Healthcare Quality and the Washington Health Alliance to really work together to move our healthcare ecosystem from fee-for-service to value. The summit that launched our framework for action identified 4 factors that facilitate that move to value: meeting a person's social needs within clinical care, interoperable data exchange, aligned quality measures, and underpinning all of that, aligned payer strategies. So as we did through last year, we will hold a 4-part webinar series using the same framework. We've organized our series so that our audience, you all, do not have to have watched the previous series. They are, of course, all available on our YouTube channel for those who are interested. So last year, as with today, we started with social determinants of health or social needs. We were joined by Sarah Singleton with the National Alliance to Impact the Social Determinants of Health. She walked us through her organization's strategies and framework to help grow our health systems to impact social needs. Allison Paulson with Better Health Together outlined how her accountable community of health is working to improve health and well-being in the greater Spokane area. And so today we will start with early learnings from an innovative pilot project at the Washington State Hospital Association with Abby Barabee and a deep dive into social needs screening and referral with outpatient care with Dr. Phyllis Cavens from the Child and Adolescent Clinic in Vancouver, and later to a panel discussion where all 3 of our speakers will be joined by Allison Paulson with Better Health Together, who will return with us to reflect on a year of progress. So again, thank you all for being here. And it's now my pleasure to introduce you to Abby Barabee. Abby received her BA from Ithaca College and her master's in public health from George Washington University. She's worked in quality improvement at the University of Chicago Medical Center and with the Blue Cross Blue Shield Association, where she established an institute that is dedicated to deploying solutions to address social and environmental determinants of health. And for the past 3 years, we have been lucky to share our region with her as she has been working for the Washington State Hospital Association as the Director of Health Equity. So Abby, thank you so much for joining us, and I will turn our stage over to you.
Great, thanks, Jenny. So thank you for having me here today. And first, I just wanted to share a little bit about my organization, the Washington State Hospital Association, or Wisha. We serve all hospitals in Washington State, and our vision is to be the trusted voice that leads, challenges, and assists hospitals and health systems to improve the health of communities that they serve. We do that through a spirit of service, integrity, collaboration, innovation, and our newest value, which we adopted at the end of last year, equity. Wisha has departments that lead work on health policy, process improvement, data analytics, and health services. We're funded primarily by hospitals through dues with some grants and government contracted work. This is a map of our membership and the distribution of 114 hospital members across Washington. We have large, mid-sized, and critical access hospitals that rely on the Wisha team to provide support for their individual needs and to achieve their missions locally. We're really proud of the fact that all hospitals in our state choose to be members. This is in no way a requirement, and we really aim to continually provide value to all of our members. I'm a director on the Wisha Safety and Quality team. We focus primarily on helping hospitals to provide safe, high quality, accessible, culturally competent, and equitable care. The team is made up of experienced certified professionals in healthcare quality with previous experience in the hospital setting in various roles, including nursing, clinical leadership, perinatal services, population health, and safety management. We also all share a passion for quality improvement, designing action plans, and using data. Our team is really energized by projects that have a meaningful impact on the health of patients in our state. We provide our services to hospitals in several ways. We gather and design content in specialized areas of healthcare, deliver technical assistance through collaboratives, and provide individual one-on-one consultation. Wisha often partners with state entities like the Department of Health or the Healthcare Authority to provide insight on health improvement strategies and to support healthcare policy implementation. Wisha was a hugely trusted voice among our hospitals and state regulators during the COVID pandemic, providing critical information to clinicians and the public as we continue to do to this day. We are uniquely positioned as a non-regulatory organization with a system-level view of hospital performance across the state. This allows us to work closely with hospitals to address the root causes of safety and quality issues and to advocate for their shared needs. The programming I lead, as Jenny said, is in health equity. And we, just like Jenny defined it, we believe that equitable care does not vary in quality because of personal characteristics such as gender identity, race, ethnicity, language, geography, or socioeconomic status. I've been working in this field about 15 years, and I'm really encouraged right now by the momentum and the engagement that we're seeing across sectors to really take action towards achieving health equity. Despite decades of evidence showing persistent health disparities impacting populations made vulnerable by racism and other forms of discrimination, progress has been slow to close the gap. I think we're seeing a real commitment to change, and I'm hopeful to see what we can all achieve together. We have a lot of things going on in the health equity space at Wisha, and it's our goal to embed equity within all of our work, and we're undertaking that in a really thoughtful and I think purposeful way. This morning, I'll be sharing work related to two of our programs, the Medicaid Quality Incentive Program and our newly launched Health Equity Collaborative. These both have components directly tied to identifying and addressing health-related social needs in our communities, and it's a focus of the Bree and the Washington Health Alliance work. So the Medicaid Quality Incentive was established in 2010 through Washington legislation to support the hospital safety net assessment. It's essentially a nice carrot to nudge hospitals towards healthcare quality goals. All non-critical access hospitals in Washington state may earn up to a 1% increase in inpatient Medicaid payments if they meet specific quality and reporting requirements. Critical access hospitals are not eligible for the incentive payments as they participate in a different type of Medicaid payment model. The MQI incentive payments are funded by quarterly assessments paid to the state by hospitals and federal matching funds. Oversight of the program is through the Healthcare Authority, and the DOH provides financial information. Wisha supports the proposal of quality and performance metrics and provides the non-financial data submission. We appreciate the opportunity for this partnership as the metrics really help to boost activity and prioritization of our safety and quality goals. Here's a list of the MQI metrics for 2021, last year. We're actually still collecting data from that reporting period through the end of this month. The metrics that we include are structural measures. Is there a policy in place for is there documented care guidelines? They include process measures like is the patient education provided? Is a perinatal consult completed? And we also have some outcome measures like falls with injury. This is the second year we've also included a metric specific to the social determinants of health. In this case, it's screening for health-related social needs. And I'll go into that in a bit more detail. The MQI SUH metric is aligned with delivery of whole person care, which I know is a priority of our accountable communities of health. It is in line with national trends that we're seeing among hospitals, and it really was a high interest of the healthcare authority. So the clinical rationale that our team put forward for this measure is that screening patients is the first step in addressing social needs. It's a key determinant of health. SDOH account for at least 80% of health outcomes. And this SDOH metric promotes screening and identification of 3 core patient social needs: housing instability, food insecurity, and transportation. We think that future Mqi metrics may focus on the linkage to community-based resources and achieving universal screening. The metric we had for 2020 and 2021 did not specify any specific type of tool or series of validated questions, although we do provide a lot of resources. The ones I recommend a lot are looking at the Health Leads Toolkit, the Prepare Toolkit, and the Core 5. The metric does specify that the 3 core needs, housing instability, food insecurity, and transportation, all need to be screened for. So to get full credit for this metric, you need to show that you're screening for all 3. And these, again, are priorities of the healthcare authority. The metric does not require all patients to be screened universally, though this really is the goal over the long run. If screening was done in at least one unit, for example, a surgical unit, or with one defined population, for example, those aged 65 and older, you could respond yes to this metric. I wanted the metric in this early stage to be able to encourage those without any screening at all to kind of get the process started. In addition to the attestation of screening for all 3 needs, participants in the Mqi metric also needed to upload a policy or a protocol inclusive of their screening workflow. This requirement is new to 2021. The previous metric really had us get a better understanding of what tools or questions were being used in the field. We'd also started to look at how frequently the responses were being coded, for example, the use of Z codes or LOINC, but we really didn't have enough information from that field to make that analysis very meaningful. So I think we have a lot of work still to do from a standardization and a coding standpoint. And I did want to share with you just some of the preliminary data. So in 2020, when we first launched this metric, we had 81 facilities participate in this metric through Mqi, and about 60% had responded yes. So we had 60% of eligible participants say that they did screen for these 3 components. Last year in 2021, we had 67 facilities participate, and a higher percentage, 78% overall, had responded yes. We're still collecting data, so these numbers might change a little bit. And I did want to note that our critical access hospital respondents are not eligible, but they still sometimes submit data so that they can provide some performance information to Wisha. And it helps inform the Wisha work so we can get a better sense of what support our rural hospitals might need. And overall, we did see a lower uptake of SDOH screening in the critical access hospitals compared to the other sizes. And this is interesting because even in those rural settings, we know that food insecurity and transportation in particular tend to be real barriers to accessing healthcare. So this breakdown on the chart here shows just the number of large, mid-sized, and small hospitals that participated in 2021. And we see overall pretty high rates of screening for those 3 components, between 80 and 88% of those participants. And so after reflecting on my individual consults with hospitals who are working to implement SDOH screening, and after reviewing all of the uploaded policies and workflows, I wanted to share some of the few emerging themes, since this is a change in action type of talk. So unfortunately, I was not able to have a hospital partner on the line with me today. I really wanted someone to provide that firsthand experience. I really appreciate the work that all of our hospital teams are doing right now to provide care for patients in this latest COVID surge. I'm hoping we can invite them back another time so we can hear directly from them. But what I saw was that with most of our large and mid-sized hospital Mqi participants, they're really using the Epic SDOH wheel. And I first started seeing the wheel, I think, in early 2020. It can be viewed by providers in the EHR, and the areas of need are color-coded for reference. Panels turn green to indicate low risk, yellow for moderate risk, or red to signal cause for concern. The feature does not generate referrals or recommend next steps, but it can sometimes include a link to a community resource site like Aunt Bertha, so that a team member can use that to look up by zip code what services might be available for patients at high risk. Aside from the delightful graphic wheel, which I really like, another theme is just the messiness that I saw and the difficulty in capturing and sharing data from the social needs screening that's being done. So some teams are capturing that by implementing flow sheets, which are more flexible and easier to share across care team members. Flow sheets may better capture updated information. Many times people's needs are changing over time. It's a little bit different than when we're just looking at race or ethnicity. And sometimes the data is pulled into a progress note or used to generate a type of risk score. Most included results in a care plan or an after visit summary report. And I only saw a couple of references to linking to community referrals through the EHR system. It's more likely that this is still being done through a social work consult or a case manager, depending on the level of risk that's identified for that patient. I'm still investigating what the experience feels like from a patient standpoint. It's unclear from the data I have so far who exactly is tasked with collecting the SUH screening info, and if that's done through a patient filling out a questionnaire or if it's done through an interview. The policies or protocols varied, but they always noted that the screening happens prior to discharge. This might be included as part of the admission process, as part of a psychosocial needs assessment, or by a discharge nurse. It's really encouraging, though, I think, to see this level of commitment via policy through their EHR engineering. It's certainly an investment of time and resources, but it's the right thing, I think, for patient care. I think we're still in very early days of translating what works for our F2HCs into the acute care setting. But this data shows that it can be done and that incentives like the Medicaid quality incentives can help to do that. I think future collaborative work could focus on the needs and implementation considerations for our small and critical access hospitals. Again, they do not benefit from the Medicaid quality incentive, and this data shows that they may also be limited by their technology. I think funding would be helpful to prioritize implementation of a process that also focuses on bolstering the community-based resources, which may be lacking. It's totally understandable to me why staff would be hesitant to ask about social needs if they don't feel they can address them. So to summarize, through consultations with hospital participants, I found that staff was really reluctant to screen without solutions. There tend to be limited community resources and networks available. It's still a very fragmented situation in our state. And that EHR documentation is challenging. So there's a move towards creating more structured data collection, so taking this out of a text note and putting it into a form that can be analyzed. But that takes a lot of time and, again, a lot of resources. I also want to share that I think incentives work. Hospitals took this on during a global pandemic. So they really are healthcare heroes in more ways than one. Do a quick time check. Okay, so I'm going to share with you next the second program that I wanted to highlight, which is the Wisha Health Equity Collaborative. This program was open to all Washington and Oregon hospitals. It was made possible by the Northwest Safety and Quality Partnership, which is between our two hospital associations, OAHHS and Wisha. To be clear, this collaborative did not provide any funding to the hospital participants. The team signed up because they were committed to the work. We have 30 teams across 2 states that are actively enrolled, and this encompasses over 50 hospital sites. This work kind of came out of 2015 AHA 123 for Equity Pledge, which builds on the efforts of the National Call to Action to eliminate healthcare disparities, and it asks hospitals and health system leaders to begin taking action to accelerate progress in the following areas: increasing the collection and use of race, ethnicity, language, and other socio-demographic data, increasing cultural competency training, increasing diversity in leadership and governance, and improving and strengthening community partnerships. Back when this pledge was being promoted in 2015, about 40% of Washington hospitals and organizations committed to the pledge, and 24% of Oregon hospitals also signed up. So we really saw an opportunity now in 2021 to share what's working across our sites and to try to catalyze more movement forward. This is an overview of how Wisha designed the Health Equity Collaborative. The goal was to enroll really highly engaged hospitals and health systems and to commit to taking action to identify and remove healthcare inequities. The draw for participants is to receive support from their peers and to access some of our benchmarking data. We reviewed many health equity frameworks noted here and interviewed a range of hospitals. We leveraged knowledge of collaboratives, including the work that we do at Bree Collaborative. We aligned focus with recent and proposed legislation, and then we pared down the 18-month focus to areas that could really be improved within these 90-day sprints. We built a gap assessment, which everyone completed prior to the kickoff last July, and we provided driver diagrams and change package with resources, trainings, and toolkits for everyone. This is just kind of outlines that structure I went over. So there's a gap assessment, we reviewed data, we have learning and action planning, there are 3 90-day sprints, a lot of peer coaching and individual coaching, and then we celebrate and learn from each other as we go. Here's a breakdown of the calendar. We're here in January. We're about to have our first report out. So all of our teams have completed their first sprint. These are the 3 domains that our Health Equity Collaborative focuses on. So leadership and culture of equity, data collection and analytics, and then the third bucket, which I think is of interest to this group, addressing social determinants of health. Here's kind of a breakdown of how we tiered some of the programming. And this maps back to the health equity gap assessment that everyone completed. So within these 3 domains, you'll see basic, intermediate, and advanced types of programs that we're hoping to advance and move forward. So at its basic level for social determinants of health, we want to see everybody screening for those core health-related social needs. We want at the very minimum patients to receive resource listings when they screen positive. We want to revisit where the community benefit funding is going. And then at an intermediate level, we want to see a shift towards warm handoff. So how do we make those connections for the patients in a little more humanizing way? We want to see adoption of closed loop referral systems. These might be community information exchanges. And we want to see the potential to deliver some services or solutions on site, either co-located within our health facilities or partnering very closely with someone nearby. And then at the advanced level, we're seeing some shift towards longer-term community investments. I referenced here the Healthcare Anchor Network. So if you're familiar with that, it really is thinking about a sustainable approach to improving community infrastructure, and then advocacy. So if we could capture data more consistently with health-related social needs, there's an opportunity to use that to advocate for the needs of our patients at a state and local level. Here's a snapshot of the gap assessment. So everyone completed this, and then we had a chance to look at the data at our kickoff in July. So here's a summary. I don't know if you can see this very well, but I wanted to show some of the baseline gap assessment results, specifically for our screening for patients with health-related social needs. So I wanted to also let you know that not all of the participants in the collaborative are hospitals. Some of them are specialty sites or ambulatory care networks. But at baseline, not surprisingly, screening for alcohol and substance use was most prevalent. 93% of our participants had that screening available. This was followed by housing at about 90% and interpersonal safety at 87%. Food insecurity and transportation were also pretty high, 83% across the board. And there's some area, I think, for improvement to include financial and utility payment support, especially during the economic challenges we've seen during the pandemic. Here's a few other questions we had sort of related to SDOH and mapping back to those programs. It gives us a sense, this first one, how widespread is the screening for health-related social needs in your community? It gives us a sense of who's being screened and where they're being screened. So as you see here, universal screening is not yet a reality for most participants. We only had 13% say that they're screening universally. Screening seems to be more prevalent in the emergency department and inpatient settings. Social determinants of health assessments are documented in the medical record by about 50% of the participants. It doesn't specify whether there's a text note or whether that's structural data. This likely reflects still that challenge that EHR systems pose and potentially a missed opportunity, I think, to analyze our SDOH data. Most people report having some internal knowledge of community resources, but it's unclear how often that's a spreadsheet versus a more robust referral system. I was excited to see the high reported use of community health workers, 53%. We definitely plan to investigate and share more about that model. And I'm curious to know if having a CHW helps prevent some staff burnout and might increase some screening rates. We see low rates of reported warm handoffs. This may be limited to the availability of social workers who feel networked into being able to facilitate those handoffs. Also, there's low use of referral management systems like community information exchanges or closed loop referral systems to track whether patients receive the services they need. This can be really expensive for hospitals. I think some community information exchanges need anchor investors to be able to set up those networks locally. And then I'm also very encouraged to see the investments in programs to address the revealed social needs. About 53% said they had something they're investing in. And one example that we're sharing with our group next week is how to set up a food pantry. And then I wanted to share too, the collaborative identified a need to support frontline staff who are tasked with collecting the sensitive demographic data from our patients. While they have maybe the systems in place to capture the information, it was still sometimes uncomfortable for folks to know how to approach and how to have conversations with patients about sensitive data. So I reached out to Ariel Singer, who is the developer of the empathic inquiry method. It's a highly regarded framework in the SUH primary care setting. She was excited and willing to adapt her training for our hospital audience. She recognized that this is an emerging audience for her expertise, and she had just finished the next version of her framework, which is now called collaborative screening. This new version includes the original motivational interviewing and trauma-informed approach, but also includes a lot of equity callouts for consideration. We're so appreciative that we could pilot this work with her, and we hope to collaborate in the future on a train the ambassador type of program. This is what her training looked like for us. We had 3 half-day virtual training sessions, so 9 hours total. These are some of the learning objectives, which include discussing core design principles and skills building for person-centered screening and referral. She also provided some organizational guidance on how to implement this at an organizational level. And then these are some of the design principles that we worked on. So the collaborative screening training is highly interactive. It's oriented towards skills development and actionable recommendations for individuals and systems. The training includes instruction and practice of person-centered screening and referral conversations, as well as review of organizational systems design and implementation planning for developing more person-centered systems. All of these materials are freely available on RL's website, and so I encourage you, if you're looking at how you can improve the skills and the relationships that are being developed by your team and your patients, to check this out. We had really high engagement when we participated in this program. We had a cap of 40 participants, which represented 11 of our teams. Demand was high, and we've already been asked to do another one. One of our teams went on to contract directly with REL to provide training to their entire staff. So as we begin to tackle the new requirements in Washington State next year to collect more sensitive patient demographic data, I think making sure hospitals do so in an empathetic, respectful, and inclusive way will be really critical to patient experience. That's the end of my slide deck. I'll hand it back over to you, Jenny.
Thank you, Abby. It's great to see what collaborative effort in the state is already doing to create action around social need and health equity. Our next speaker, Dr. Phyllis Cavins, is going to talk about her own clinic's experience integrating social needs into pediatric primary care. Dr. Phyllis Cavins founded the Child and Adolescent Clinic in 1978 and is currently the clinic's medical director. Dr. Cavins has 38 years of experience caring for children as a pediatrician and also founded Children's Community Resources, a nonprofit organization devoted to helping children in the Longview, Vancouver area with unmet medical needs. Dr. Cavins, thanks for being with us today.
Thank you very much for inviting me to be the voice for pediatric primary care and the social determinants of health. And thanks also for the opportunity to address this social need as we're trying to build a competent system of care for children. So let's begin by talking about children and families and why they need a system designed for them. Children and families throughout Washington State have struggled with the impact of the COVID-19 pandemic. They are faced with the impacts of social determinants of health, economic difficulties, family stressors, falling behind in school, lacking important developmental opportunities, experiencing worsening behavioral health, and missing wellness visit with their primary pediatric clinician. We need to build an equitable system of care that addresses the whole child, including social determinants of health, along with behavioral and physical health, Children must be our priority. The system of care is first and foremost a set of values and principles that provide an ongoing framework for system reform on behalf of children, youth, and families. This system of care should be family-driven, youth-guided, home and community-based, strength-based, individualized, and trauma-informed. There must be a commitment to health equity through cultural and linguistic competencies, connected to natural helping networks, resilient and recovery-oriented, data-driven, quality and outcomes-oriented, plus coordinated across providers and systems. There should be system reforms for mental health, child welfare, juvenile justice, and advanced patient-centered medical home. There should be a population health focus across all child-serving systems. Primary care innovations include advancing patient-centered medical home, behavioral health integration, care coordination, team-based care, plus addressing social determinants of health and health equity. The Center for Healthcare Strategies has developed a toolkit for states entitled Advancing Primary Care Innovation in Medicaid Managed Care. The toolkit outlines strategies to achieve primary care innovation goals, targeted primary care delivery system goals, and design considerations for advanced primary care initiatives and innovations. The Healthcare Authority, the Washington Healthcare Authority, has identified their key priorities for 2022-2025 that focus on primary care, health equity, and social determinants of health, with the priority of increasing access and engagement in whole person care. HCA's vision for value-based payment is to use their data-driven policy and purchasing power to continually drive the healthcare system towards improved outcomes, patient and provider experience, and equity while containing costs. Mental health is the costliest condition of childhood, more than what we pay individually for the care of asthma, trauma, or infectious disease. Children in Medicaid who use behavioral health are an expensive population, costing 4 times as much as children who do not use behavioral health services. Children in foster care cost 5 times as much, children on SSI cost 6 times as much, and children whose families are in TANF and extreme poverty have expenses twice as high. The prevalence utilization triangle illustrates the degree of complexity of the needs of a population as it relates to the amount, type, frequency, and costs of services required to meet those needs. This population applies to the pediatric population and their physical, behavior, and social needs. The more complex the need, the more intense the services, the more costly they become. But all children need prevention and health and wellness promotion services. Some children need outpatient, community-based early intervention supports and service. A few children need intensive inpatient services. We could improve quality and equity, plus be cost effective, if we, instead of spending 60% on intensive services for 5% of the population, we could decrease it to 50% and add 5% to outpatient services and 5% to preventive services, essentially doubling the amount on universal preventive services to children. Pediatric primary care in the patient-centered medical home has the opportunity to integrate behavioral health, address social determinants of health, reduce health disparities, and coordinate whole person care. We know that 75% of children with diagnosed mental health disorders are seen in the primary care center. Racially and ethnically diverse families especially feel less stigmata in pediatric settings rather than in behavioral health settings. A 2013 study in pediatrics found that youth of color, low-income youth, youth from households with limited English proficiency, and those with mental as opposed to physical health condition are less likely to have a medical home where they could obtain family-centered care from a trusted physician. There have been similar findings with respect to the lesbian, gay, bisexual, transgender, and questioning youth. Bree Collaborative in 2017 described the levels of behavioral health integration into primary care as the way to achieve quality care for both behavioral health and primary care. They addressed the fundamental components of integrated behavioral health and described what advanced behavioral health integration in the patient-centered medical home would look like. Advanced integrated behavioral health components are co-managed care plans, close to same-day access, registry and tracking, systemic follow-up, risk stratification and protocols, plus specialists readily accessible or on-site. Without this care-driven advanced behavioral health integration, it is clear that screening without adequate treatment or referral to specialty care without coordination or co-located and integrated behavioral health specialists without systemic tracking of outcomes or evidence-based treatments do not restore the patient to good health and are not recommended. University of Washington in 2020 described the STEP strategies for behavioral health integration into primary care as it related to increasing patient complexity and intensity of behavioral health services in an integrated primary care approach. This STEP strategy describes roles and services of primary care, the services of primary care panel management, and what that would look like in a collaborative care model. In pediatrics, we have utilized the Bree hybrid for collaborative care management, where the pediatrician makes the diagnosis, treatment plan, prescribes a medication, and consults with the local or regional child psychiatrists or the University of Washington PALS line. The unmet need for care coordination is high for children and youth with mental health condition, but equally so for those with developmental needs, physical health needs, and social determinants of health. The care continuum relates to the intensity and frequency of care coordination. Again, all children need age-related developmental, environmental, behavioral health, and social determinants of health screening, plus maternal depression screening. When there is a positive screen during a well child visit or parental concern at any visit, there is a referral for needed services and support. When there is a child with identified behavioral, physical, or social needs, service coordination and system navigation is required to support an effective response to an identified need. Children identified with complex behavioral, physical, or social need require intensive, customized care coordination with extensive cross-sector support for these multimodal needs. Care coordination ensuring community clinic linkages, the role of the health navigator. Pediatric Advanced Patient-Centered Medical Home is a system of care coordination consisting of health homes, comprehensive care management, referral to community and social support services, comprehensive transitional care, individual and family support, coordination of care, health and wellness promotion, and prevention and early intervention. This care coordination system allows access to a pediatrician, early and periodic screening, diagnosis, and treatment, behavioral health and social health screening, co-managed care plans, comprehensive electronic medical record for the child's life trajectory. This system of care would ensure community clinic linkages with the hospital, schools, behavioral health agencies, community child serving organizations, and DCYF. The nurse care coordinator, with the addition of non-licensed health professional or health navigators, would ensure care of the whole child, regardless whether they are seen through the lens of being a patient, a student, client, family member, foster child, institutional care resident, or transitioning to an adult. The Washington Accountable Communities of Health Medicaid transformation projects were maternal and child health, integrated behavioral health, which included social determinants of health and health equity, the care coordination project, and the care coordination project, which focused on the pathway model, utilizing community health workers and health navigators. The integrated behavioral health and care coordination projects were required for every HCH, and integral to all projects were how to address social determinants of health and reduce racial inequities. In each of these medical transformation projects, as partners in the projects, we aggregated national emerging best practices, synthesized best practices that were meaningful into our community and region. We developed strategies and action plans for our Medicaid transformation projects that we track for outcome. Child and adolescent clinics projects were advanced PCMH, integrated behavioral health and care coordination, which we illustrated in the prior slide. At the State of Reform in January 2022, there were presentations on the new social determinant imperative and health equity. The social determinants of health presentation made note of the fact that social determinants of health are important and it's imperative we do something about them. But doing something to employ that knowledge in a meaningful and sustainable way is still elusive. The SDOH panel discussed the intersection between delivery system and community and the lessons learned from the ACH work to connect the two to improve conditions where we live, work, and play. The social equities panel noted that social determinants are the primary drivers of health. They also acknowledged that these influences are not equally spread across geography and demography. The presentation explored what was known about that uneven spread and discussed strategies to bring about greater equity in how we address social factors in health. Taking action in social determinants of health in clinical practice and the community requires these steps. Ask the patient about social challenges in a sensitive and caring way. Record social determinants screening results in a data strategy, data registry. Refer patients and help them access benefits and support services. Improve access and quality of care for hard to reach marginalized patient groups. Partner with community groups, public health, and social services organizations. This county social determinant of health dashboard on the Washington DOH website collects standard SDOH data regarding poverty level at or below 125% of federal poverty level by county in comparison to other counties and the state, and the demographic data regarding age, race, and sex. For example, in our region, Cowlitz County shows that the poverty rate is 20.5% compared to the state average of 15%. We can analyze and benchmark this data by county and region to inform the clinics and community agencies, and also to demonstrate need and value to payers. We must be aware of the fact of the devastating consequences of growing up poor. Living in poverty, even temporarily, is detrimental to a child's cognitive abilities, emotional control, and overall health. The cost to society is incalculable. CPA, our ACH, in January 22 held a Health Equity Mini Summit Learning Collaborative as an effort to convene, coordinate, and lead efforts to address social determinants of health and reduce racial inequities. We hope to gain a better understanding of the volume, scope, and challenges of social determinants of health in our region and the community. One of the stakeholders presented data regarding social determinants of health at their federally qualified clinic and found in a 5-month period, 28,828 patients visited the clinic and completed a social determinants of health screening. Of the 85,995 visits with screening, there were 875 referrals, about 1% of the screens. Of those referrals, 34% were homeless, 7% spoke a language other than English, and 36% were from an underrepresented racial or ethnic group. Community partners and cross-sector collaboration. The $1 million Southwest Washington COVID outreach grant allowed organizations to recruit and train a community-based workforce consisting of 12 community health workers who were members of a marginalized community by race, ethnicity, or spoken language with social vulnerability, and were already employed by a community-based organization. They became available then to clinics and organizations to provide culturally and linguistically appropriate outreach, education, and access to COVID-19 testing and vaccination. Advancing behavioral health access in rural Wahkiakum County linked resource-rich Cowlitz County to those who needed transportation and communication in that neighboring rural county via a care coordinator and health navigator. The 21 Southwest Washington nonprofits grant funds covered the program and staff expense to participate in a statewide network, United Washington, to help more people in need connect to services. Unite Us assists state and local organizations to build and scale coordinated care network, track outcomes together, identify service gaps and at-risk populations, and empower members of the community to take ownership of their own community's health. A locally funded community partnership between Child and Adolescent Clinic and 3 Cowlitz County School District strives to achieve the best possible health and academic outcome for homeless students by providing access to health care and food for approximately 5% of the students who are homeless, 1/5 of whom are unaccompanied minors. The Washington Children and Youth Behavioral Health Work Group over the past 3 years heard presentations from parents and professionals, reviewed national emerging best practices, and made final recommendations to the legislative staff to be formulated into this document, SB 5894. Senator Frock introduced SB 5894 at the 2022 regular session to be enacted by the legislators of the state of Washington. The legislators finds that whole person care that includes access to behavioral health, care coordination, and social supports at the point of entry is essential for families. Managed care organizations shall make reimbursement for care coordination services performed by non-licensed staff acting in the role of a care navigator available to primary care clinics. Health navigators become part of the healthcare team to help individuals overcome barriers and facilitate their access to services. SB 5894, when funded, will provide coordinated whole person care that ensures resources and care for children with behavioral, physical, and social needs. Thank you so much for listening.
Thank you, Phyllis. That was great. And look forward to kind of the panel discussion now.
I guess I was thinking I was supposed to do something with Allison's introduction. So Allison Polson will be part of our panel discussion. Want to make sure that we all know who she is, as she is the Executive Director of Better Health Together. And you heard a little bit about the Accountable Communities of Health. The Better Health Together is the ACH that serves 6 Eastern Washington counties. Good to have some geographic variety here. And the tribal reservations of the Kalispell, Spokane, and Colville tribes. She has been the executive director there for 8 years, and prior to that spent about 20 years in different types of not-for-profit leadership in both Seattle and Portland. So she and Dr. Cavins and Abby will be part of the panel that we're going to chat with today. And thanks for allowing me to kind of do this Q&A session. We had many questions coming in the chat. Let's see if we can get to them. There's some that are kind of yes or no things, but I think for both of you, Dr. Cavins and also Abby, you've talked about data that may have been collected. And I think particularly for Abby though, are any of these data shared with the ACHs or the insurers? So what you're collecting from your hospitals, I think mostly is what they were interested in.
From my standpoint, not that I know of. So we do have hospitals and health systems that participate in the coalitions that have been set up by the ACHs regionally. So it's up to them based on the projects they might be collaborating on together, what data they share. But through the work that I presented today, the Medicaid Quality Incentive and our Health Equity Collaborative, we're not submitting any data outside of that.
People were interested in that. And we did have a question from Sarah Green, who I recognize as a key member of the Washington Health Alliance group. Nice to hear from Sarah. And she wanted anyone who wants to comment on it, basically about the role of interoperability, where it seems like in listening to your 2 presentations that there's a lot of different things that are kind of going on at a lot of levels, and how we can bring together some of the, the data you're collecting around social determinants, some of the work that we're doing. So it doesn't seem like there's a million things kind of going on, and how we can bring that together. She wanted to know about the impact of interoperability. Any respondents there? Dr. Cavins, I see your mic's off, so good.
In the practice of pediatrics or in primary care in general, at the patient level, interoperability occurs because we make a referral, and at the time of the referral, we ask the family, can we share your information, and they sign a release of information. And if the child serving organizations do the same thing when they refer to primary care for assistance, that is managed very easily. So we, as much as we would love to have one system that we all could pay for and be together on, a release of information is probably still the best way to protect the patient's confidentiality and then serve the patient, to have a co-managed care plan, and with exchange of pertinent information. This is especially difficult with behavioral health care and with social determinants. People are not proud or not happy, or really don't want everyone to know that they're homeless or that they have a mental disorder. So having interoperability via release of information, I think, is probably from the patient's point of view, the preference.
Probably. it's the most common way that we're achieving it right now, I think, is by human work and human contact. Allison, do you have comment about the impact of
I'm just going to add into the mix that I think interoperability feels a little pie in the sky overall for what we're seeing. But I think there's some areas of really important community collaboration to be thinking about, which is really around the resource guide part of this. And that as we see lots and lots of interest from big technology companies coming in and offering closed loop referrals and so forth, the technology piece is one element of it. The other piece is how are we equitably ensuring that resources are getting to folks, and not just because you're a patient at this place who has a relationship with this social determinant of health partner, you're getting those types of services. So one of the areas that we're paying a lot of attention to is, could we start to build out our resource directories more as a community utility? And then whatever the technology platform that the individual providers choose to use becomes much more aligned with some of their business strategy and their quality strategy, as Dr. Cavins was saying, rather than a competitive advantage based on who's got the best access to resources.
I just noticed that Ginny had asked me to to give you, Allison, a few minutes to just discuss what you are doing within the ACH there. And sorry.
I'd be happy to just keep taking questions. I think that might be more relevant to the group, and I'll weave in some of the work that we've been doing over this last year, if that works. I'll say on the interoperability side of things, we have been acting as a care coordination hub under contract with the Department of Health to provide the social supports folks need to be able to isolate and quarantine after a COVID diagnosis. And that has included connecting people to rental assistance, to utility assistance, to cell phone assistance, to food, and PPE equipment. So we see that hub infrastructure role being really important into how we're going to connect the healthcare system with the rest of those community resources. And it really speaks to our advocacy around the resource guide and how we are really focusing on the lack of a organized social determinant of health sector, as we're seeing more and more interest from the healthcare sector to connect to.
I know that just recently there has been a little bit of a step forward with regard to interoperability and maybe the formation of actually useful HIEs going forward. So maybe we'll see that happening. And I know, Abby, you mentioned that most of the hospitals in our state, not all, but most, do use Epic. And so you've been able to kind of take advantage of some of that with your collaborative. But have they talked about, being able to reach out into the communities and to other organizations, even skilled nursing facilities and others, and how they're facing that?
Yeah, and so Epic is one of the main vendors, but they're not the only one. And so I think as you talk about standardization and interoperability, I think it's important to include our EHR vendors in that conversation, because there's a lot of time, I think, that gets sunk into requesting custom builds or workarounds for systems, where if these become more standard practice, then I'm really appreciative of the work that the Gravity Project is doing around standardization and coding. It just makes it that much easier to implement, and we can spend more of the time focused on developing relationships with patients, developing relationships with community organizations. I think that's where the real work still needs to happen. And so having more standardization and clarity on the back end, I think, just frees up more time to do that. And I want to note too, in Sarah's question, she had asked about how that helps to move the health equity needle. And so I just like to get on my soapbox again and say that it's important to screen for health-related social needs, and community information exchanges are important too, but those are still just Band-Aids. So we need to think about health justice and everything that we're doing. So I think having standardization and sharing data and making that easier to do is a tool. And we should be using those tools to really have advocacy and to change policy and to think about the long-term impact that we want to have. So this is important work, but to move the health equity needle, we need to transform our societal systems, and that takes a lot of collaborative effort.
Exactly. I couldn't agree more. There's a couple of big buckets that I'd kind of like to ask folks about now, and I hope I'm capturing what I'm seeing coming in through the chat and the Q&A. You've all talked about the various activities that are going on. It seems like there's a lot of funding being put out to do things in different sectors and a lot of activity. And you all just mentioned it, you know, with regard to interoperability, which is that right now, it's mostly people doing the work, and we, you know, making those connections, reaching out, understanding who's in your community, you know, making the best of what we can. But, you know, knowing that we have a staffing shortage everywhere, and, you know, looking at Dr. Caven's very impressive slide showing everything the health navigator will do, and thinking that person is a superhuman being to do all of these things and is very, very busy. How do we make this, you know, all of these wonderful goals real, given the fact that they're all heavily person and labor dependent, and we just kind of don't have enough people right now? And everybody's input would be wonderful.
This is Dr. Cavens. Just a comment on the labor shortage and the increased social needs, and how do we address that? It's certainly in behavioral health specifically, but the concept that the legislation developed for us, and hopefully if passed will fund, will provide employment for non-licensed folks, and they would become part of the healthcare team that would enable more people to be involved in integrated behavioral health, rather than where it is in some communities, a referral system with long waits and then no shows, and all the talented behavioral health therapists, which you waited 3 months to see, is sitting there with no patients to see because of no shows, because of social determinants of health. So the missing link seems to be not more. It would be nice to have more behavioral health therapists, but to have more integrated behavioral health into primary care, where 75% of the problems are already being taken care of. And if we would add to the healthcare team a non-licensed professional who would receive on-the-job training of how a system works to connect needs with services, that would go a long ways to addressing the workforce shortage. And it would also give a very valuable, meaningful employment to people with a new title of a health navigator. There aren't enough nurses to go around. There aren't enough certified medical assistants to go around. But with on-the-job training in a clinic site, I believe, and also from the Children's and Youth Behavioral Health Workshop, the workforce group plus primary care really pushed to have this legislation. And it's also very cost effective. Markedly decreases no shows. And if people receive services early with the first social crisis, instead of after being chronically homeless, or after being on 3 antipsychotics, or after all these late things that use up behavioral health resources and uses up dollars. So we're very excited about this legislation, and hopefully it will pass, and hopefully it will be extremely adequately funded.
Extremely adequate. That's kind of how I describe myself most of the time.
Good. I'll affirm that.
Allison, can you comment a little bit about that at the ACH level? I know that one of the priorities there was, to integrate, whole person health and, with all the issues facing everybody, how do you deal with it when it's highly person dependent and there's not very many persons?
Well, I think the last couple of years have exacerbated what was already just a really severe shortage in workforce, and I would venture to say a little bit in the who's delivering care in what way kind of thing. And we have definitely seen some pockets of just really exciting work through our ACH efforts, in particular Volunteers of America, which is both the lead for our youth experiencing homelessness efforts, as well as providing some transitional housing and shelter housing for women. They have really embarked through this integration process from moving from, we're going to partner with primary care and behavioral health to support our, I want to say roughly a couple thousand people that they are managing in housing, to becoming a credentialed behavioral health agency and employing a care team that can actually support their set of residents, which has really resulted in some better stabilization of their residents, who are also now their patients, in that way. So we see some evolution starting to come, but the workforce issue is so incredibly critical right now. And I think we're not able to really address where could we be using peers to help support behavioral health versus credentialed social workers, psychiatrists, et cetera. How are we getting more prevention happening in the primary care setting so folks don't get to as an acute of issue? I'm super proud and pleased that in our region, the number of folks who are adding behavioral health into the primary care setting, not as a partnership, but really employed behavioral health professionals, where if you have somebody coming in for an annual exam who needs a much more than a warm handoff connection point being made, that is actually being made. That just has exacerbated the problem, though, for our community mental health centers. So we're probably not even pushing the decks on the lanai, or whatever the phrase is in that way. We've really got to look at the overall behavioral health workforce. But I think there's some places where we're seeing some promising knowledge. I will just highlight in this past year that we have used some of our Medicaid waiver funds to provide supervision financing to a number of our community health center or community mental health providers, so that they could really address some of the workforce issues, because what they were finding is their contracts weren't sufficient to be able to pay for that supervision to get more people in, and that the level of clinician that was coming out of school and needed that supervision, needed a much more dedicated resource in that way. So we've been able to build up a little bit of capacity in that way through some of that funding. But I think we've got a long way to go, and some of that is in our social behavior of how we think about mental health and substance use as an illness, not a moral shortcoming, and being able to really connect people in a setting that feels comfortable to them.
Abby, it's the same question, but as you were speaking, I remember you said that a lot of the hospitals in the collaborative are saying that they do, collect certain things, but then when you got down to the nitty gritty and said who's actually doing it, kind of at which level they're collecting information and then kind of acting on it, the numbers shrank a little bit. And so one of the people in the Q&A kind of commented also, like, it's a concern to the commenter that we're screening, but without resources to kind of deal with it. It seems like some people are asking the questions, but not all. And then what do you do with the information, and how what have you learned through your, efforts through the Medicaid and through the collaborative about how those participants are dealing with those issues? So let's move from collecting to really collecting to doing something.
Yeah, it's a great question. I think it also kind of ties into the workforce challenge as well, because we're seeing a lot of burnout. People are stretched very thin, and it doesn't feel great to screen for an issue if you don't have a solution to provide to patients. So when we first thought about adding the screening metric to MQI, it is kind of a chicken and an egg problem. Like, where do you start? Like, we know that people don't have everything all set up. Is there still value in screening for a social determinant if you don't have everything in place to refer them? And so the first thing that we realized is that there really are more resources within hospitals than we had realized. It really was a matter of communicating that across the care team. So a social worker might have a list of resources or connections that they use, but that hadn't been distributed. So packaging that into some easier flyers or flow sheets or things that anyone on the care team could access, I think made a big difference. So there's that first piece of just knowing what you have inside your own system and being able to use that more efficiently. And then the other thing is, there's just a lot of variation in sort of who's engaging and how they're doing that. We know it's really important to ask the patient permission before you start screening for these social issues. That's different than how we might do screening for other types of functionality prior to discharge. So it's a cultural change, sort of being able to engage in a conversation, do that in a way that's patient-centered and really respectful of people, especially when they choose not to participate in the screening. And I think that's where we wanted to have more education for our participants in the collaborative, just understanding sort of the legacy of healthcare systems and how we've created some really good reasons to have mistrust of the healthcare system. So it's not just a question, it really is bringing up some historical trauma that might have been experienced by a community. So we don't want to ignore that. So in our metric, we said, let's just try to focus on getting the screening up and going for whatever population you feel like that's most appropriate for, that's easiest to get started with, and then learn from that. So we don't have to do everyone all at once. We don't have to do universal screening all at once and kind of deal with the complexities of that, but start in small steps and then over time get better at that. So the idea is that as you expand screening, as you add more domains, as you expand to more patients, you're also building up your resources and you're also learning from the data, which is why structuring the data is an important step too, because if you don't have an understanding of what needs you're going to find, it's really hard to kind of make those connections and do community investments that match and align with what patients will be looking for. So it is a whole system that we're trying to achieve. But from a healthcare quality standpoint, we have a pretty good history of being able to break that down and create sprints and sort of think about what's the next phase and move on from there. And what I love about Washington is that all of our hospitals, we don't compete on quality, we actually collaborate on quality. That's unique, I think, to our state. So we're willing to share and get into the messiness of it. And I do think that over time, we're going to get better and better. And I'm hoping that we'll have systems that kind of support us outside of a clinical setting as well to make that easier to do.
Certainly, they're all excellent answers. And I think as with everything you say, there's more questions that just pop up and we don't have unlimited time. There's a couple really directed questions. Someone wanted to know, and thank you, Dr. Cavins, for your presentation, and wanted to know if there's any efforts afoot, and you can all answer this as far as you know, about trying to ensure more support. This would be, fiscal coverage probably for more integrative health mechanisms. So, things like massage therapy, mindfulness-based therapies, acupuncture, those things that have been shown to help people with their, stress and other anxiety, other issues. Are those issues that you have faced? And the question was initially addressed first to Dr. Cavins. So your remarks there and go around.
Thank you for that question. Thanks to the value of integrated behavioral health, I can always punt to the behavioral health therapist in the clinic to answer those questions. But from my understanding, yes, there are many non-traditional methods and approach to problems that children and families have, but I rely on the expertise of the behavioral therapists to match. There's a change in view. We don't look at children need therapy. Children need help with their behaviors so that life at school and life in their family is happier, better. Now, indeed, there are some children with very severe mental diagnosis, behavioral health, substance use diagnosis. But in general, early in primary care, if we have an integrated therapist, they can devise a co-managed care plan that includes non-traditional, quote, medicine. Yes, we're very, very open to that. In this sort of whatever works, as long as it's at least performance-based and hopefully evidence-based.
I think there's a real growing evidence base for a lot of these therapies for different conditions, including, pain management of multiple kinds, as well as behavioral health needs. So any comments on those types of therapies or approaches being tried or paid for?
Well, I'll just make a couple of comments, not with my ACH hat on, but I do sit on the School Employee Benefit Board. And it has been really interesting as we have rolled out the consolidation of all school employees into a single state-run system, how much requirement and request for expanded massage, acupuncture, and physical therapy requests have come through. So there's I would say a moderately generous benefit there. And I think one of the challenges we see is enough evidence-based research to help support that. And as we live in a managed care setting, I think, that how do you manage those pieces and really demonstrate the outcome feels like a challenge. We see with a lot of our community-based care coordination, looking for donations of massage and acupuncture for some of our Medicaid patients. So I don't think that's a real robust benefit at this point that I think is a place for us to work. And I think the more we have the medical community weighing in and saying, yes, this is a viable option. And quite frankly, probably the more we move into value-based care, the more willing we'll all be to examine what works for this patient versus this patient versus this patient.
Anything to add there, Abby?
I guess just one thing that comes to mind more from a patient standpoint is that I think benefit design is important and the medical evidence to support that, but also just thinking about the different types of workers that we have. And even if you are afforded a medical benefit around acupuncture therapy, just being able to take the time off to do that. So I think translating this into what's really feasible and preferred by patients is also important. So making sure that their voice and their experience is included in that, because I think you can fool yourself into thinking that we have a benefit, but people aren't taking advantage because they can't really take that time off. So just putting that patient component on it too.
I mean, hear a lot of things kind of coming through. It's like, we got to get the allopathic providers to believe the evidence and then use it, but then we have to have benefits that cover both the access to the providers, but also the ability to get there, to have the time off and be supported in that way. I know, Nick, we're getting close to the end of the session. I have a quick question, and maybe Nick, you can answer it, or somebody mentioned State Bill 59, is it 5994, 5984? I wrote the number wrong. 5894. Someone wants to know which group is behind it. Is that Senator Frockett's bill?
5894. Senate bill. Yes, and that funds health navigators in primary care.
So that would.
And yes, so that's the basic thrust of it, and require managed care to reimburse for that service. The budget proviso has not been written for that, but it's in progress. How best to pay for that, per member per month, a prospective lump sum payment, and it would have to go to primary care that we're doing integrated behavioral health at an advanced patient-centered medical home, and are addressing social determinants and have a care team. So it isn't it isn't just quote available, but it has to have readiness for it. But then if funded, we could add that person. Already through ACH funding, for our patient base of 15,000, we have 6 health navigators. And this is related to the hospital situation. There's a statewide collective medical technology and system that all hospitals are connected to, that with a health navigator, we have real-time information about our patients that are in the emergency room, and whether it's physical health or behavioral health. And so that we can devise the care plan for discharge from the ED while the patient is there, and arrange for same day follow-up the next day, or encourage a present appointment to be kept. And that's one full-time health navigator to manage that. But markedly improving quality, decreasing costs. And our partner also on this is the managed care organizations, because this, when you refer to data, they tell us our rate per 1,000 of ED visits. They tell us the patients that have cost more than $20,000 in the past year. They tell us the patients that have been to the ED more than twice in the past 6 months. So with that data and with this collective medical approach and with a health navigator, I don't have the data of dollars saved and quality improved, but it's certainly there.
It really does sound like there's definitely ways that you and your practice are moving forward to higher value care. So the care is more valuable to the patients and at less cost. And I think the answer to the questioner is, because they want to support this bill, it's Senator David Frocht. So Frockt, and that would be probably the person's office to contact about that. Nick, we are down to 4 minutes. So did you want to finish the conversation now? I want to thank everybody. I have so many more questions. It's like both sides of a piece of paper. So we could have gone on for hours, and I think everyone just continues to comment and say how valuable this all is. So thank you all so much. Next, put up my little slide. Oh, so the Washington Health Alliance is, I think, along with everybody else, very interested and have a strategic priority to work on health equity. One of the things we're going to be using, and many of you have heard of, the Area Deprivation Index, which has actually now been renamed as the Neighborhood Atlas. If you have extra time and you want to do something fun, go out to have you done this, panelists, since I can see you? Go out to Neighborhood Atlas. It was developed by the Department of Medicine at the University of Wisconsin. It takes 17 indicators, none of which are related to health. There are things like % of residents within a geographic area that are in under the federal poverty level, who have, single parents, who have less than a high school education. There's a whole bunch of they're strictly social and economic indicators. And you're able to look at a zip code level or a zip +4. So that would be essentially a census tract level, and divide all those up into basically percentiles of socioeconomic challenge. So the higher the number, the more socioeconomic challenge the people have. No, I think it's the other way. It's the other way. The lower the number. And you can divide up into percentiles for the entire United States or just within a state. And this has been used many, hundreds of times by universities, researchers, thousands of times, even asking lots of different questions about the impact of place, of residence on people's, you name it, impact of disease states and ability to access this, that, and the other thing. And so this is something that at the Alliance, we are definitely looking into in terms of our all payer claims database and working on identifying potential ways to stratify some healthcare associated metrics by this disadvantage index. It aligns really closely, fairly closely. There was a study at Brookings that said that the area deprivation index is a reasonable proximity. It's more than 80% concordant with essentially race and ethnicity. And the larger, of course, your base of population is, the more it kind of adheres together. So looking forward to seeing what the results are of that, and hopefully sometime later this year. And so I talked out all of your minutes, Nick, but I think that's what I have to say.
Yeah, thank you, Sharon. And thank you to our panelists for being with us today and sharing your expertise from your communities. And thank you to all of our attendees for coming and being willing to learn about these value-based changes that our healthcare system can make. We've put up on the slides just the dates for the next webinars in this series. Our next one will be on April 7th, 2022, and we will be focusing on interoperability. So we'll be sure to let everyone know when the registration link for that webinar comes out as well. Thank you again for being here, and I hope you have a wonderful rest of your day.
Thank you.